Bismillah ar-Rahman ar-Rahim. In this lecture, I'll be discussing the treatment principles of malignant bone tumors. By the end of this lecture, you're supposed to answer the following questions. You have to know what surgical margins are, what is limb salvage, and what are the contraindications to limb salvage. You'll be able to know the different reconstructive options used after resection of bone tumors, and how do we choose among them. You know the rationale of chemotherapy in treating bone tumors, and you know the rationale of radiotherapy in treating bone tumors. First of all, we have to remember that a patient with a bone tumor is not necessarily suffering from a local disease, but in many types of bone tumors, it is actually a generalized disease. So he has a tumor in the bone, but also micrometastasis in blood. If we think of him as a localized disease and just treat his bone tumor, eventually he'll develop metastasis and die. So we have to treat him both locally and systemically. Different bone tumors are treated differently, whereas tumors like chondrosarcomas are treated with surgery alone. Osteosarcoma, on the other hand, is treated by both surgery and chemotherapy, whereas Ewing sarcoma is treated by chemotherapy and surgery or radiotherapy as a local treatment. So why do we give chemotherapy? There is a very common misconception that chemotherapy is given just to facilitate surgery, or it's given to decrease the size of the tumor, whereas this is not the aim of giving chemotherapy. Chemotherapy is given to target the micrometastasis in blood. So it's a crucial player in the treatment of bone sarcomas. It's only given to types of tumors that are chemosensitive, like osteosarcoma, Ewing sarcoma, and fibrosarcoma. And it's given either following surgery, what we call adjuvant chemotherapy, or before surgery, what we call neoadjuvant chemotherapy. So it's given before and after. Several drugs are used, like adriamycin, cisplatinum, high-dose methotrexate, and all these are given as a multi-drug regimen. If you give a single drug, it usually causes drug resistance, but when you use multiple drugs, you decrease the chance of developing drug resistance. Obviously, there are chemotherapy toxicity affecting the heart, the kidneys, the bone marrow, but most of these toxic side effects are manageable. Radiotherapy, on the other hand, is given for radiosensitive tumors, which accounts for most of the round cell tumors. It's given in a fractionated fashion. And all the recent technology always aims at giving the maximum dose to the tumor, but sparing the adjacent normal tissue. It also has early and late complications. Surgery, which is the main topic of our lecture today, could be either amputation or limb salvage. But whatever you do, whether amputation or limb salvage, you always have to achieve what we call a wide margin of resection. So what is a wide margin, and what are the surgical margins that we should know? Enneking divided the surgical margins into 4 types, either intralesional, marginal, wide, and radical. If you look to the picture on the right, this is the tumor in the middle and surrounded by a pseudocapsule, which is in the yellow color, and then the white and red are the normal tissues. If your resection margins goes through the tumor, like when we do curettage, this is called intralesional margin. And obviously, this is not suitable for malignant tumors, it's suitable for benign tumors. If you go remove the tumor by passing through the pseudocapsule, the yellow color, hence you remove the tumor in toto, but micrometastasis will be left behind. So this is also suitable for benign tumors and not suitable for malignant tumors. If you go through normal tissue, when you remove the tumor with a cuff of normal tissue, this is called a wide margin. If you go and remove the whole compartment, this is called a radical margin. The minimum margin required for treating malignant bone tumors is a wide margin. This is an example of an osteosarcoma to demonstrate how the margin looks. And if you look at the microscopic picture, this is the tumor tissue, and this is the bone and periosteum, and these are the attached muscles. So in these 2 millimeters, you can see that the tumor is covered by bone, periosteum, and the muscle attachment. This is 2 millimeters of margin. Is this a wide margin? Yes, definitely it is. So a wide margin is defined by the quality of the margin. That has to be free of tumor tissue and not by the quantity or the size. So 2 millimeters of normal tissue is a wide margin, so as 2 centimeters, so as 20 centimeters. All these are considered wide margin of resection. So how do we define limb salvage? Limb salvage means the preservation of a functional limb after adequate oncologic resection of the tumor and reconstruction of the resultant bone and soft tissue defect. So when do we do limb salvage? We ask ourselves 2 questions. Will limb salvage offer the same oncologic margin as an amputation? If yes, we go ahead. Will limb salvage offer a functional limb that is superior to an amputation fitted with a prosthesis? If yes, we go ahead. So there are 2 prerequisites: to have a safe oncologic margin and to have a resultant limb that is superior than an amputation. So when do we not do a limb salvage and do an amputation? Mostly in situations in which we cannot achieve a wide margin of resection, like if we have an infected, open, or misplaced biopsy, when the neurovascular bundle is involved by the tumor, when we have a mobile pathological fracture with hematoma dispersed around the surrounding muscles, or in very young individual, in which even if we can do a safe limb salvage, the reconstruction that we do cannot cope with the leg length discrepancy in the future. Limb salvage is composed of 2 components: resection with a wide margin and reconstruction of the resultant defect. The types of resection are either intra-articular resection, like when we go through the joint and remove the distal femur or the proximal tibia, or extra-articular resection, in which we remove the tumor together with the adjacent joint closed when we have an intra-articular extent, or intercalary resection when the tumor is in the middle of the bone and our resection is away from the joint. Reconstructive modalities are many. We classify them into 4 groups: either biological reconstruction, which is here in the green color, either autografts or allografts. The autografts could be vascularized graft or non-vascularized. The vascularized could be free or pedicled. The non-vascularized grafts could be classical, non-vascularized, or recycled bone. Allografts could be osteoarticular or intercalary. The second group is the endoprosthetic group, and it includes modular prosthesis, custom-made prosthesis, expandable prosthesis, and 3D printed implants. We can also have combinations, reconstructions which are composed of allograft and a prosthesis, recycled bone and a prosthesis, allograft and vascularized fibula, recycled bone and vascularized fibula composites. And we have the miscellaneous group, like bone transport, centralization, rotationplasty, and in some cases we don't do reconstruction, like when we resect the proximal fibula or parts of the pelvis. So how do we choose among these many reconstructive options? There are factors that influence our choice: the age. What we do for young individuals is different than adults, the size of the bony defect, the site of the bony defect, and the available muscles after resection. In order to have a mobile reconstruction, we need muscles to move them. If we have to remove all the muscles, we'd resort to something that causes joint fusion. The need for adjuvant chemo and radiotherapy, the sex of the patient, the occupation, what he needs this reconstruction for, and the intelligence to use sophisticated reconstructive options. We'll pass through different reconstructive modalities in different sites of the body so that you can have an overview of how we use these reconstructive techniques. We begin with the humerus. This is an osteosarcoma of the proximal humerus after resection and reconstruction with a modular prosthesis. This is an osteosarcoma of the proximal humerus reconstructed with a vascularized fibular graft, can see how the fibula hypertrophies with time. Another technique for reconstruction is the pedicled scapular crest graft which is the lateral border of the scapula based on the circumflex scapular vessel, and we use it to reconstruct the proximal humerus, like in this case of an osteosarcoma of the proximal humerus. And you can see here the pedicled scapular crest with shoulder fusion. Epiphyseal transplantation is used in children to maintain the length of the humerus. After resection of the proximal humerus, we use the proximal fibula, vascularized based on the arteriotibial vessels that supplies the epiphysis to maintain the length of the humerus. Intercalary humeral resections are usually reconstructed with vascularized fibular graft. Distal humeral defects, like this patient with a metastatic thyroid cancer, resected and reconstructed with a modular prosthesis. For distal radial reconstruction, we usually use non-vascularized fibula with wrist fusion. This is a patient with a Ewing sarcoma of the metacarpal, which was resected and reconstructed with recycled metacarpal bone. Following scapulectomy for malignant tumors of the scapula, we usually use no reconstruction. We suspend the humerus to the clavicle or chest wall. Now we move to the lower limb reconstruction. This is the chondrosarcoma of the proximal femur, resected and reconstructed with a modular prosthesis. This is a Ewing sarcoma of the proximal femur, resected and reconstructed with a vascularized fibula and hip fusion. Intercalary resections of the femur, like the humerus, are also reconstructed with biological reconstruction, like a vascularized fibular graft. This is an osteosarcoma of the distal femur, where we spared the condyles and reconstructed the defect following resection of the tumor with a composite of an allograft and a vascularized fibula inside. So, and here you can see the pedicle of the vascular pedicle anastomosed to the main vessels, and the fibula would give the viability and early union, whereas the allograft would give the durability and of the construct. You can see how it heals quickly here. Osteosarcoma of the distal femur, reconstructed with a modular prosthesis. And when all the quadriceps are involved, like in this osteosarcoma, we reconstruct with a vascularized fibula and knee fusion. You can see how it hypertrophies to reach the size of the original femur. It's a durable reconstruction, but with a fused knee. In children, osteosarcoma of the distal femur and reconstructed with an expandable prosthesis. And the expandable prosthesis allows us to increase the length of the prosthesis with time so as to diminish the leg length discrepancy. There are different types of expandable prosthesis. This is another type that is lengthened by an electromagnetic field. And you can see how the length increases by time. Another method for reconstruction for children, like in this patient with a huge osteosarcoma of the distal femur, in which we did a rotation plasty. It's done through a rhomboid incision, which we resect everything apart from the sciatic nerve. And then we do anastomosis of the femoral vessels to the tibial vessels and fix the proximal femur to the tibia. This is the brace that he uses for rotation plasty, and you can see here that whenever he does dorsiflexion of the ankle, he's doing flexion of the knee, whereas plantar flexion of the ankle causes extension of the knee. And he walks with a brace. It's a very functional reconstruction and superior to an amputation. For tibia reconstruction, this is an osteosarcoma of the proximal tibia, resected and reconstructed with a modular prosthesis. When we do hemicondylar resection, we usually use allografts. This is a hemicondylar allograft after resection and fusion. Intercalary tibia reconstruction is reconstructed with pedicled fibula, ipsilateral pedicled, vascularized pedicled fibula from the same size. For distal tibial resections, like this patient with the distal tibial osteosarcoma, it's resected and reconstructed with a pedicled fibula. You can see how it hypertrophies with fusion of the ankle. Pelvic resections are usually reconstructed by fusing what remains of the bone, like in this patient with an ischiofemoral fusion or an iliofemoral fusion. And this is the chondrosarcoma of the iliac bone after resection and reconstruction with a non-vascularized fibula to close the pelvic ring. Sacral resection do not need any reconstruction, they're just resected, like in this patient. So what is our take-home messages? By the end of this lecture, you should have known what surgical margins are, what is the definition of limb salvage, and what are the contraindications to limb salvage. You should know the reconstructive options following resection of bone tumors and how we choose among them. You should know the rationale of chemotherapy and rationale of radiotherapy in treating bone tumors. Thank you very much.